Hello everyone, my name is Puriya Mushaidi. I'm a vascular neurologist and neurointerventionist at Tehran University of Medical Sciences. I'm very honored to be invited on this panel discussing thrombectomies in medium vessel occlusions. Should we still treat them? And my take is we should not. I have no conflict of interest, and speaking in front of a group of neurointerventionists and say that do not do thrombectomy is giving me a feeling that is best depicted in this slide, how I divide roles between myself and Dr. Alrohaimi. So let's first start with talking what is a medium vessel. So we know what large vessel is. Large vessel are basilar arteries, internal carotids, and the main branch of middle cerebral artery. And anything beyond that is considered middle vessel, medium vessel, including PCAs, ACAs, and M2, MCA branches, M2s. There are some nuances. We know that there is an anatomic variability on how M2s are branching. The main application here is sometimes you have a dominant M2s that you see here. One M2 is bigger than the other one. And sometimes you have co-dominant M2s and obviously a non-dominant M2. So a dominant M2 is actually a large vessel occlusion, as they have been included in other LVO trials. And non-dominant or co-dominant M2s are in fact medium vessels. And the medium vessel occlusion trials published so far include all the medium vessels, but majority are M2s. So let's take a step back. When Dawn trials were underway and it was published, I was a resident at UPMC. We often had this discussion with my mentor, Tudor Jovin, who would argue astonishing number needed to treat of 2 for any improvement after thrombectomy, any functional outcome improvement at 90 days may indicate that we own a very effective treatment, but may also show that we are being very over-selective in a group of patients, meaning that we are able to exclude any patient with lesser likelihood of benefiting from thrombectomy. And so we usually select patients based on the last known normal, degree of disability, the location of occlusion, and the infarct volume. And so the next generation of trials, which the MeVO trials belong to them, is starting to testing those boundaries. So going beyond the time limits, the publication by my very good friend Shashwat Desai showed that if you select patients that are in the Dawn criteria would be included, except the time of onset, even going as far as 72 hours, they would have the same benefit as patients in Dawn. So they successfully crossed the time limit, although it's not within our guidelines yet. And then we're all aware of the large core trials. This is the one by Dr. Saraj that the number needed to treat dropped from 2.1 to 7.7, but they still showed a benefit for thrombectomies. But so the second line was crossed successfully. But are we able to go from large vessel thrombectomy to medium vessel thrombectomy? And even before starting the trials, was it expected to help? So let's look at the subgroup analysis of the early time point thrombectomy trials and the Hermes meta-analysis. So I want to draw your attention in the subgroup of M2s, which were included in some of those the 5 trials. The subgroup of M2s actually did not benefit from thrombectomy, and also those that their NIH stroke scale was less than 10. So the milder stroke symptoms. And this is important because actually looking at the patients with medium vessel occlusions, the presenting NIH stroke scale is in average 3 points below large vessel occlusions. So you're dealing with a less disabled group of patients, let's call it. And then looking at the subgroup analysis of late time window EVT, this is from Diffuse 3, the same thing showed up. So the subgroup of patients with milder NIH scale, again, they did not benefit from thrombectomy. So this is how we entered the information we have before doing the medium vessel occlusion trials. And there were some studies on the PCAs and ACA showing that ACA thrombectomy would not change the outcome. They were non-randomized, but still, I think they're worth mentioning. And then there was a observational study on PCA thrombectomies that, in fact, it showed that thrombectomy will cause a higher rate of symptomatic ICH and a worse recovery. So this is how we entered. So I want to use this nice picture from the publication by Goldberg and colleagues. We have two published trials, Distal and Escape MeVO, and Discount, which is not yet published. Correct me if I'm wrong. This is the baseline studies. So what I want to draw your attention to is that each study was enough powered, and they were trying patients with different time points, less than 12 hours, less than 24 hours, less than 8 hours. And they were also variable and allowed different devices to be used. Some obliged the operator to use the stent retriever, some gave them flexibility. So the results that would come from these trials will have generalizability to different times of onset and different device usage. The outcome, again, this is part of the baseline characteristics. You would see that in all the trials, both Discount, Distal, and Escape MeVO, the patients that were included, as expected, they were presented with milder stroke symptoms. So you are doing a procedure on a patient that is much less disabled. Remember, the average of patient in Dawn were about 5 or 6 units higher in an NIH scale. And then the symptomatic ICH in all the trials were really considerable. In Discount, it was 12%, in Distal, it was 5.9%, and 5.4% in Escape MeVO. And then I want to again compare it with the meta-analysis of large vessel occlusion thrombectomies, that the symptomatic ICH with only 4.4%. So you are treating a patient, treating group of patients with milder symptoms with a more risky procedure. So have this in mind. And then in terms of outcomes, so we have the Escape MeVO and Distal, which showed no benefit in outcome at 90 days. As you see, the confidence interval will cross the value 1. And the Escape MeVO, in fact, showed a higher rate of 90 days mortality, which was significant in interventional group. So it shows that we're not only benefiting, but we are at some point harming. So one word of caution that Discount results, which were preliminarily presented in ISC, it showed that there was a significant improvement in thrombectomy patients for the MRS score equal or less than 2 at 90 days. But this was this annotation at the bottom after multiple imputation of missing data. So I don't know what it means. I don't know what it would turn into when it comes out as a full paper. So we have to look out for it. So we are talking about the thrombectomy in a group of patients or in one patient that they're facing. You're doing thrombectomy in a patient which has milder symptoms in a risky procedure. But I want to also take this discussion into a global health level. So this is the picture from MT Glass study, Mission Thrombectomy, which shows the access of different countries to thrombectomies. As you can see, even the good countries colored in green, only about a third of patients eligible for thrombectomy have access to it. The situation for other countries is dismal. Majority of MENA countries have less than 10% access to thrombectomies. So what I'm feeling that as neurointerventionists, although we have a duty to bring the best for our patient, But it seems that we have a more pressing and urgent challenge, meaning that improving access to thrombectomies for large vessel occlusion. You know, we are living in a world that the resources are limited, so we can invest in finer devices for middle vessel occlusion thrombectomies, as we saw that the thrombectomies in this population is more risky, so maybe we can argue our devices is not prepared for it. But we can also invest that time and effort and money in making LVO device thrombectomies more available. And that is the subject of grassroots trials, bringing a stent retriever in with a lesser cost, so that it could widen its coverage. It actually came out from the Mission Thrombectomy Initiative. And I think it got approval in India, if I'm not wrong. It got approval in Thailand before it. So as a neurointerventionist, when I'm facing the MeVO study, we can talk about like different um, uh, pieces of information that we have. That for MeVO, we are treating patients with milder symptoms. Our procedure is more risky, causing higher degree of symptomatic ICH, even mortality. We have less successful reperfusion and no proven functional outcome. But I think we, as a next step, if I have a choice of going after improving the devices and finding refining trials for smaller vessels, or trying to widen the very dismal global coverage for mechanical thrombectomy for LVO, I would definitely choose the second one. So my answer to doing thrombectomies in medium vessel occlusions is no. Then I'm leaving a stage to my very good colleague, Dr. Alrohaimi. This is a picture of Tehran from the hospital that I work with. Hopefully, we can all meet there. And thank you for your attention.